Thank you. Good afternoon, everyone. We're towards the end of day 2, and we are getting ready for the keynote session in neural engineering. You guys will remember from yesterday's seminar by Dr. Ochia, she mentioned 2 fundamental traits associated with the biomedical engineering profession: interdisciplinary or multidisciplinary, and translational. Colleagues, today's keynote speaker, Dr. Brian Litt, fits this description to a T. After earning his bachelor's degree in engineering and applied science from Harvard, he went to Hopkins to complete medical school and his neurology residency. Armed with this education and training, Dr. Litt developed over the years world-renowned clinical and research programs in neurology and neuroengineering, predominantly at the University of Pennsylvania. The primary focus of his work is on epilepsy, but you don't have to look hard to identify his contributions and interests in other brain network disorders. His interdisciplinary approach merges engineering with clinical and systems neuroscience in various ways. Some examples include automated implantable diagnostic and therapeutic devices for brain disorders, analytics of seizure generation and prediction, analysis of neuronal signals using machine learning and higher order statistical tools, and brain-computer interface. Dr. Litt has received many accolades for his clinical and scientific contributions. To list a few, he's received the Dreyfus Penry Award for Epilepsy Research, the Hans Berger Award for contributions to EEG research, the Brain and Behavior Foundation Distinguished Investigator Award, and most recently, the Luigi Mastroianni Clinical Innovator Award. Currently, Dr. Litt is Professor of Bioengineering and Neurology, joint appointment at Penn. He serves as the Director of the Center for Neuroengineering and Therapeutics, and he's also the co-director for Penn Center for Health Devices and Technology. Based on the information that I just provided, and given what you will hear and see from Dr. Litt himself, you'll agree that his work checks off so many boxes that define a biomedical engineer. I'm thrilled to introduce you to our keynote speaker, Dr. Litt, as he tells us about engineering the next generation of neuro devices and their creators. Dr. Litt.
Great. Well, thank you so much for that kind introduction. Too kind, actually. So today I'm kind of charged with telling you a little bit about my career, the science I do. I can't resist, given my extended age, giving you a bit of advice and some perspective at the same time. Since many of you are students, my hope is that this will hit you at a really good time to be useful. All right, so the first thing is about conflict of interest. So these are companies that I'm engaged with, have either helped co-found or consult for, and none of them are really influencing this talk, except in the sense that I think this is a goal of people in bioengineering. You know, one of the most important things for me as a clinician and an engineer is that I want to get my ideas and my technology into the hands of people and to help people. That means interacting with industry. You know, it used to be that you could build something in your garage, like if you hear the story of the first pacemaker that Alfred Mann, founder of Medtronic, made in his garage. You know, he used to repair EKG machines and got the idea for turning a metronome circuit into electrodes that you could use to pace the heart. So I can't do these things alone. I have to work in conjunction with industry. That means that you have to have integrity, that you have to manage your conflicts, not avoid them. So there are a bunch of these companies, you know, that either make devices and implants like MC10 or whole devices like NeuroPace. This is a new one that you'll hear about more called Hyperfine, which is a low field MRI in a cart that's under $50,000. So I work with these companies and try to do so in a way that keeps my science separate from commercial interests. The good news is that I've never made a dime from any of these ventures, and hopefully it'll happen posthumously, but it's not my main goal. My main goal is impact, not profit. All right. The work I'm going to present to you is team science. And it's important to realize that no longer can people do things. I mean, there are folks that invent MRIs and light bulbs and new technologies, but the kind of translational work I do relies on a team. So this is my team from the Penn Epilepsy Center with clinicians, nurses, nurse practitioners, fellows, and then staff. And then similarly, this is our group in the lab, the Center for Neuroengineering and Therapeutics, which has three main PIs, myself, Flavia Vitale, whose work I'll tell you a little bit more about, and also Catherine Davis. Kate is an MD and also does neuroimaging. Flavia Vitale, a PhD in chemical engineering and material science, who works on brain implants. And then all of the students and postdocs and undergrads who are involved in the lab. Well, I think my purview is to tell you a little bit about career trajectory, particularly for those of you who are students. And so this is a plot that on the x-axis has my decade in life, and then two curves. In red is happiness, and in blue is how much I think I know. And so you can see these bumps: graduating high school, getting my engineering degree, getting my MD. You know, in education, you really think as you learn more material that you know quite a lot. But then when you go into actual practice applying the knowledge, when I was an intern, I realized how poorly educated I really was in terms of translating what I had learned in the classroom into practice. But as I got more experience as a fellow and then an assistant professor, I really felt like I was at the top of my game. This was my first real job. But then as I started to dig in, see the other faculty around me and learn the challenges of getting grants, doing research, I realized I didn't know quite as much as I thought I knew. Tenure was a real boon. You know, you feel like you know your field well, but then as you delve in more, get more experience, you realize that you know less and less. This doesn't mean that I'm getting more stupid with age, although my kids might say differently. What it means is that I have a much better appreciation of how much more there is to learn. The good news is that happiness in general, for me, has dramatically improved or steadily improved over the course of my lifetime and my career. And I think, you know, if we do it right, this is something you can look forward to too. There's no doubt that these bumps in happiness kind of correlate roughly with the amount of knowledge I think I have, but then there are real highlights, you know, life milestones. And this is important to keep perspective about things that are really important to you. Getting students, getting postdocs, getting married, having kids, founding my center, getting an endowed chair, kids graduating college is huge. Right under here, it should say like become financially independent, and then founding a new venture, Penn Health Tech. So the good news is you are going to, you know, appreciate more how much you don't know over time. But in general, if you continue in this field, you know, happiness, I think, is pretty easy to attain. It's wonderful work. All right. So here's some pearls to take home with you, particularly for the students. The first thing is figure out what's important to you. Don't let other people have you spend your time or devote your life to working on things that they think are important, but you don't. For me, patient care, developing new technologies that really help people, that's important to me, as well as family and balance. Know your strengths and use them. You know, if you can't compute your way out of a paper bag, then computational neuroscience probably isn't going to be your thing. If you have practical skills, use them. If you're a good theoretician, use them. If you're really great with people, that's a tremendous strength. And, you know, even if you may not be the strongest technically, if you can work with other people and find good collaborators, that's huge. Find a mentor. That's not somebody who signs your registration every semester. Find somebody who's going to show you their scars, tell you what they've learned from their experience, who's going to write letters for you, make phone calls, really help you get to the next step. The next thing is you do not have to know everything right up front. You don't have to know where you're going to end up, because I guarantee you're going to end up in a place different than what you think. Navigating a career is sort of like being on a sailboat. You kind of head for you aim for the horizon, but as you get closer to the shore, you'll figure out better as you have a view of things where you want to go. It's okay to say, here's what I'm going to do for the next 5 years. It's long enough to plan, to make progress, but not so long that it locks you in forever. And along with that, don't be afraid to take chances. If you have a great opportunity to do something, and you're not tied down, don't be afraid to take a chance, but make sure you vet it appropriately. Pick your thing. Pick something that's important to you and make it important. Show its significance. Be creative. Pace yourself. It's fine to make gradual progress. Don't aim for the bleachers and hit home runs all the time. Careers are built out of singles, base hits, doubles, more than the occasional science paper that's rare. And then I'm a firm believer that you should be happy. I think the happier you are, the more productive you'll be. So we'll come back to those at the end, and I'm going to tell you at least how I've approached some of these things in my career. So we're going to go on a whirlwind tour of kind of the science I do and why. Oh, by the way, things you need to succeed: common sense, really important. You can be the most brilliant theoretician, but at the university a month ago, I saw somebody texting walk in front of an ambulance with its lights on and its siren blaring. There isn't any education that can substitute for common sense. Fortunately, she didn't get hit. Grit, you have to have tenacity. It's not going to be easy. Remember, the work you do, if you do research or development, is failing 90% of the time. And it's those rare successes, that little bit of incremental progress you make every day, that makes it worthwhile. Creativity, you have to be creative. Think outside the box. Don't be afraid to come up with new ideas or question why people do things. And I'll show you some examples. Integrity is really important. If people respect you and know you'll do the right thing, they'll trust you. And most importantly, feel good about yourself. If you do these things, pursue what you're good at or what you have talent for or stuff that's important, and respect yourself, those are vital. All right. I pick collaborators that I like. Why should you be miserable in your work? And many of them are people that I've found who have common interests, people like Danny Bassett, people like John Rogers at Northwestern, some of my favorite trainees like Greg Warrell, John Viventi, Bill Stacy, Joost Wagenaar, who was at Pitt and CMU, and other folks, neurosurgeons, neurologists, statisticians. You can never get a straight answer out of them. It's always maybe. All right, so I'm going to show you a case. This is a 22-year-old woman who presented with seizures that did not respond to medication. A third of the world's 60 million people have seizures. 60 million people with epilepsy have seizures that don't respond to medicine. So she continued to have seizures. She gave up her career as a physician. She had this MRI, which shows an abnormality in the left occipital cortex. It's a malformation. She was evaluated at a center. They couldn't find a real clear-cut cause. These are normal variants, a slightly bright hippocampus on the left, but her seizures didn't come from there. And she had an operation to try to localize her seizures. They removed this part of her skull. They put a big grid of electrodes over her brain and a depth electrode, which they wanted to aim for this abnormality, but missed it. They couldn't figure out where her seizures came from. And so they did a procedure then in 1999 that they don't do anymore. They dragged a probe over her cortex to disrupt the connections to try to stop her seizures. It worked for about a month, and her seizures came back worse. And it did this to her brain. It gave her this atrophy. The cortex should look like this, more normal, but it gave her all of this atrophy and scarring. And there's the dent and hole in her skull from where they put the bone flap back. She continued to have seizures and came to see me 15 years later. The technology had changed, and the MRI showed a bright spot at the bottom of this sulcus, with a little tail going towards the ventricle. We know now that this is a cortical dysplasia, that the brain cells didn't migrate normally when her brain developed. These cells should have been here in the cortex to make it look like this, but instead they got stuck and ended up in a clump there. A very common cause of seizures. Unfortunately, when you see the trajectory of the depth electrode that was placed at the other institution in 1999, you could see that they did it by hand. They didn't have any steering MRI guidance for technology then, and they just missed the area, which was lower and in a different place, and they didn't know it was there. So we evaluated her again. And by the way, in those years, the choice was either to do that subpial transection where they scraped across the cortex, or to remove a huge hunk of brain, which in this case would have paralyzed her on the other side, taken away her vision on the left, and made her completely non-functional, never able to drive and not able to use her dominant side. It wasn't an option. So they did big resections or just scratched the cortical surface or nothing. We monitored her. Here's her EEG time series. This is a seizure. It starts where the arrows are. This is left temporal, right temporal, left subtemporal, right subtemporal, left temporal, right temporal, left parasagittal in the middle, right parasagittal in the middle. You see this rhythmic activity and then all this artifact, but you can see this spiking, and it's in the posterior region on the left, but not on the right. It's coming from over where that abnormality is. We did a PET scan to look at glucose metabolism. It's down in this whole area where the cortex was damaged, but nowhere else. We injected her with a tracer that binds to brain according to the amount of blood flow in a single pass. It was injected right when she got her seizure, and lo and behold, it lights up where that abnormality is and moving forward under the temporal lobe. So everything points to this region. And the question is, what could you do? Well, nowadays, we mapped her visual fields. She went and had a stereo EEG study. So the EEG electrodes are placed, guided by MRI and the computer through burr holes into the brain, into the region around the electrode. Now, it turns out at this time, Penn had only done about a dozen of these cases, and they wanted to go to another institution where they had done more. They went to the other institution, and this is where the data is from: three-dimensional MRI, the robotic trajectories. They recorded seizures from the depth electrodes, but you know what? You see the spike, but you see it's flat here and then rounded. You see it kind of come in here rounded, here rounded, here rounded. They basically didn't put an electrode where the seizure was coming from. Here's another one where you see the spike again. It's kind of this flat area, and then it starts in a broad region all at one time. So the group there decided that they would make a lesion kind of in this general area with a laser. This is thermal laser ablation. You can see where they've simulated it with the computer. Here's where the location is, and here's the lesion that was made. And you can see that it's not exactly where that cortical dysplasia was. The seizures stopped for a period of months. They're vastly improved, but they're not gone. She has them occasionally every month or two at night out of sleep. They're mild. She can drive now. She's on less medicine. Her depression is better, but she's not seizure-free. Making a lesion in the network that gives rise to her seizures improved her, but didn't make them go away. By the way, we got the imaging. We got the electrode locations, which we co-registered from the MRI and the CT. There's the dysplasia, and you can see how the depth electrodes missed the location of it. So the issue is, how can we make this better? She actually unfortunately lost a little bit of her visual field from the damage here. She's still able to drive. It's in the superior quadrant of the left side. So this top kind of pie in the sky, if she looks left up, she doesn't see things. But the question is, how could we make it better? Did we need to use a laser? How could we guide electrodes better to find the location? Where in the network should we put a device? Should we lesion? How do we understand how seizures are generated? How do we treat these people who don't respond to medicines? So what I've devoted the last 25 years of my life to, basically, are to try to understand seizure generation, figure out how to map epileptic networks, develop disruptive technologies, train and mentor people, and accelerate science through data sharing. So here we go. We've developed new hardware, materials, and implants, new informatics, algorithms, and made use of the cloud, new devices, and then technology for data sharing and publishing. So seizure generation. I saw a patient when I was down on the faculty at Emory and Georgia Tech who had seizures, but said she could feel warnings before the seizures occurred. At that time, it was about, I left Georgia Tech in 2000 or 1999. So it was in 1996 to 99. I was trying to understand, working between Emory and Georgia Tech, how seizures began. And I took her data. We monitored her with electrodes inside of her head for a period of a week. And I looked at her data by hand the entire week, 10 seconds at a time. And what I found were that there were these little bursts. This is 1 second, 3 seconds, 5, 10 seconds, that looked like seizures, but weren't long enough. And when I mapped them by hand, I saw that this is the frequency of these bursts in time leading up to seizures. I looked at her EEG. This is a period of 2 hours before, or an hour before her seizure, which is here. And then we developed features, particularly one line length from one of my graduate students at Georgia Tech, to pick up these rhythmic bursts before the seizure occurred, and you can see them building up. As a result of that, and looking at a bunch of patients, 15 of them, we looked at their seizures, saw when they started to stray from the baseline, seizures in red, baseline in blue, and figured out that seizures actually appeared to begin up to hours before they actually started, that they kind of popped and fizzed and generate bursts, seizures, almost like a match trying to light a fuse, and came up with an idea for a device that would classify these events, extract features, use a neural network, develop probability of seizure onset, and stimulate to turn them off. And that was in conjunction with a colleague, George Vaxavanos, who was using early machine learning techniques that would classify these events and pick them up. What that turned into, a company of group of people from the defibrillator industry were interested in working on the brain. They founded a company called NeuroPace, and this is the device. It can have strips of electrodes, up to 8 contacts in 2 separate electrodes. This is a depth electrode in the hippocampus. This is a strip electrode. Battery, it extracts 3 features from the EEG, detects when seizures are about to begin or when it looks like they begin, and stimulates to turn them off like a defibrillator. Medtronic later developed a similar device that's an open loop stimulator for the subthalamic nucleus, and now a number of different companies are working on these devices. This is a tracing from one of my patients, and you can see this, each one of these vertical lines is a second, and you can see in this minute that there are little bursts that the device stimulates to try to turn off. Then the seizure begins. It stimulates 5 times with the same stimulus, does not stop the seizure. This is state of the art for this device. Patients come in and have their parameters tuned by hand. And on average, this is a tracing over 3 years of a measure of seizure activity, bursts, taken periodically from her device. And you can see that over a period of years, her amount of activity reduces and goes down. Unfortunately, this patient died, and you can see the activity stops. There's a change in her here. The fact is that these devices, now in 3,000 people nationwide, are reducing seizures by about 70%. They're on to something, but they're not perfect. It's a work in progress, and a lot needs to be done to understand where to put the device to stimulate, how should you stimulate to control seizures, can you predict whether somebody's going to respond, how do you change the parameters in a logical way to improve them. So these are the things we've needed to conquer. We have our first device out of the gate. We need to do better seizure detection because the detector works sometimes, but it often stimulates on false positives hundreds of times per day because the three features in that detector are crude. We'd like to be able to predict seizures ahead of time. Our early work showed that they start and kind of brew up to hours ahead of time. We'd like to know when, where, and how to intervene. Power is a huge thing. I don't work on power for batteries for these devices, but computing power, which is directly related to how big the batteries are, how long they last, is key. And how do we teach them and improve? So one of the first things we did was to work on algorithms for seizure detection. A number of people had worked in the field for a long time, and we got the idea of why not leverage the crowd? Why not put a Kaggle competition in place? And we did this in 2016. It was December of 15. And what we did is had two competitions, one for seizure detection and one for seizure prediction. And what we did is put up a training set for each. We had a $5,000 prize for this, a $10,000 prize for this, and a $15,000 prize for this. 3-month competitions that were consecutive. Here's the progress area under the ROC curve in the 3 months of the seizure detection study. And look at this detection. It's almost one for the training set, for the testing set. As a matter of fact, the winner, and we required that in order to collect the prize money, and there were prizes actually for second and third place as well. Look at this, 0.962 under the area under the curve. So here's the question for you guys who are students. You know, was this like a tenured professor? I mean, I've been working in this field for 20 years at the time. And who is it that could beat me, that could do better than me, right? I mean, it had to be somebody great. You know, after all, like I'm a tenured professor at a major institution, right? Let me show you what great looks like. It's not a tenured professor. Here's the winner explaining what he did. It's a kid. He's 2 years out of college in Sydney, Australia, works in his basement.
Hi, my name is Michael Hills. I'm the winner of the UPenn and...
Oh, you know what? Actually, I don't know if you can hear me. I'm going to go back and just unshare for a second. And I'm going to reshare and share the sound. See, my students have taught me something.
I was able to hear you, but...
All right, very good.
Hi, my name is Michael Hills. I'm the winner of the UPenn and Mayo Clinic Seizure Detection Challenge, and I came in at 5th place on the American Epilepsy Seizure Prediction Challenge. Ben has asked me to make this short video to tell you a bit about myself and to describe my approach to both competitions. So first up, about me, I'm from Sydney, Australia, where I studied computer engineering at UNSW. I've been out of uni for about 5 years, in which time I've worked doing low-level embedded systems for a couple of years and joined a web startup for a couple of years. Now these days I work as a consultant with my colleague, doing web server backends and mobile apps for early stage startups. We try to have a bit of downtime between clients so we can work on our own things or even just take a break. So in my own time, I've been studying machine learning, having taken Andrew Ng's machine learning course on Coursera, as well as studying digital signal processing. So I started to form some design goals. The framework I would build should reuse previous computations and never recompute the same thing twice. It would also need to allow me to try different data pipelines and different classifiers as quickly as possible. Without any domain knowledge of seizures or EEG signals, this would at least let me experiment very rapidly. So I also chose to write everything in Python as I was more familiar with it than R or MATLAB But Python also has the excellent scikit-learn library, which meant I had a wide range of classifiers that I could just swap in and out and easily see what works better for this data set.
So not too shabby, right? I mean, was he like a full professor? No. Michael actually was 2 years out of college, took an online course for machine learning and digital signal processing, but was really smart about what he did. And he killed the field. Like, he didn't kill it. I mean, he just did a superb job. And the winners now, those algorithms are publicly available for seizure detection. And it showed that using the crowd and sharing could really do huge things. The prediction competition was even more successful. The prior 15 years, the NIH had spent and the European Union had spent $40 million on grants for seizure prediction. And the best results were 0.65 under the ROC curve, 3-month competition, $25,000 prize, 0.84. The group that won never met each other. It was a student from Australia, a graduate student or a postdoc from Germany, and 2 engineers from Silicon Valley. And they did a superb job. Now those algorithms and showed that seizure prediction could be done with significant accuracy, and now we're working on refining it better for devices. Francis Collins, the head of the NIH, had written about this in his blog. So what happened?
Can I interrupt you just for a second? There's someone who has a hand raised. Maybe it's a question or something along those lines.
Yeah, sure, of course, Elaine.
Sorry about that. I hit that by accident. I apologize.
I don't mind if you guys interrupt. As a matter of fact, I prefer it. You know, when I teach my class, I usually quiz the students, you know, but don't hesitate to ask things. I don't want to be one of those boring guys. I mean, more than I am already.
Oh, somebody else has a hand up now.
Okay, shoot.
Provided the encouragement. That is impressive, the contrast between, 20 years of NIH funding and 3 months of this open competition. But a little bit of caveat there is that the people who did it in 3 months had this benefit of tremendous amount of knowledge generated in various parts of this thing, jigsaw puzzle. So really, this slow and steady growth in knowledge, should not be discounted, simply because they got it in 3 months.
So absolutely. And I'm so glad you said that. Basically, they had the benefit of us setting up the problem, right? We picked the data, we picked the training set, picked the testing set, made sure that they generalized. By the way, the testing set was private. They had to submit their algorithms and we ran it ourselves on the data. But that's a really important point, and I'm so glad that you said that. Those students would have not been able, Michael Hills would not have been able to win that competition without all of the domain knowledge and the 20 years or 15 years of preparation for it. That said, there's a huge amount of benefit from leveraging the crowd and getting people to, participate who have knowledge and skills that might not, otherwise have participated in the field. So the next step was to try to turn these prediction algorithms into a device. And so a startup company, NeuroVista, approached us, and they did a trial in dogs with epilepsy that have the same frequency of seizures as humans, the same incidence, and then in a human trial of 15 patients. They had a really creative device, which was rechargeable, which would transmit to a handheld computing unit, which would show a white light if it couldn't decide, a blue light if the chances of having a seizure were very low, and it was trained individually for each patient for the next hour, and a red light if the probability of seizure was high within the next 30 minutes. One of the first things they found, this is each one of these horizontal lines is a day for this particular patient. The lightning bolts in yellow are seizures. The patient reported these seizures. She was very tired during the day. We didn't know why. And it turns out the device recorded all of these seizures at night that she was not aware of. Here's an example of the best patient performer in the group. This is a month. Each one of these horizontal lines is 24 hours. You can see the blue periods, which showed that said the patient was not likely to have a seizure. The patient found these blue periods liberating. Data were collected for 3 months before the patient classifier was trained, and then it was updated periodically. So it was trained in such a way that a seizure never happened during the blue periods. And during those periods, the patient felt safe to go to the store, go outside, take a shower, do things like that. All of the seizures were predicted in advance, the red lightning bolts, with about 5 false positives over the month. This patient became so reliant on the output of the device that he actually weaned off his medications and only took a rescue medication when the light went red, so that he didn't have to take a medication every day. Now, only a few of the patients got this degree of benefit out of the 15, like 4 of them. Most patients got some benefit, 2 patients got none. It proved the principle of a completely different paradigm for treating these patients. Unfortunately, during the economic downturn, this company went out of business, but one company, LivaNova, who is an investor, still owns the technology. There are a number of different groups still working on this to embody it in an implantable. A really important finding of this study, here are the subjects, all 15 of them. Here are the number of days that they were monitored. Here are the number of seizures the patients reported on average per month. And here are the number of seizures the device actually detected. You can see patient reported 6 seizures per month. The device detected 80 on average. What it showed us was that patients are not reliable in reporting their seizures, and some report more seizures than they actually had. They're just not aware of them because they're often amnestic for them. That shows every major drug trial for epilepsy is based upon seizure diaries. So the FDA requires that device trials are based upon seizure diaries. This is one of the reasons that seizure therapies are so poor, is that the quality of the data is awful. So there's been a move to make a number of devices for monitoring and reporting seizures. This, by the way, is a grant that we have with the Mayo Clinic, with Greg Worrell and his group in collaboration with Medtronic, but there are other companies that are working as well on building a better seizure detection and prediction device. The RC plus S rechargeable, unfortunately, the company has just made it a research device only. They will not be commercializing it, which is unfortunate because it has a great toolkit for developing devices. We're also working on research to try to use some of our network neuroscience to figure out who's going to respond to neurostimulation from a device before the device is actually implanted, and working on better ways to converge and titrate stimulation. There's a lot of work on implantable, minimally invasive devices like this one from UNEEG. It's a privately held hearing aid company in Denmark, but there's several others. Cochlear, the cochlear implant maker, is working on one. Devices that go under the skin to monitor seizures so that patients will no longer have to rely on remembering whether they had one or not. This is an output for one of those subscalp devices in a human, a single seizure recorded on both sides. And this is 8 hours from this patient showing 2 seizures, and just a simple threshold detector will pick them up above all of this noise. So a very active area for our group and others is making seizure monitoring devices as well as detection and prediction devices. So that's one phase of our research. Another one has been on biomarkers. When Greg was a postdoc in the lab, it was felt that this showed desynchronization in the intracranial EEG and then the seizure onset. We found out that that was completely wrong. Intracranial EEG was recorded in a bandpass of 0.1 to 70 hertz, which was the same as pen and paper machines, because the ink pens above 70 hertz would splatter ink everywhere. What we found was that if you looked in higher frequencies, the seizures started at much higher frequencies. It started a bunch of research based on looking at high resolution temporally and spatially. This is what Greg looks like now, and Bill Stacy, who's associate professor at Michigan, putting in 40 micron microwires to detect high frequency oscillations and these high frequency seizure onsets. Justin Blanco, who's a professor at the Naval Academy now, was in the lab and developed unsupervised classification methods to map these. And Bill and his group and several others are now using these high frequency oscillations to localize epileptic networks. Unfortunately, sometimes you need to record for over 30 minutes to get a good idea of the spatial distribution, because they can occur in normal brain too. We found that they can occur at a very high spatial resolution, sometimes in cortical columns. And the clinical electrodes are on centimeter scale, just like the frequency imaging, going at 70 hertz rather than a kilohertz, which is what we use now to look at intracranial EEG. The spatial electrodes of 1 centimeter scale, like the old electrodes I showed you, were built because they were the technical limitations of the electrodes when the technology was invented in the 60s and 70s, and that persisted. More recent work with the Utah array has shown higher resolution discharges, but it causes damage to brain, and there is a need for higher resolution, minimally invasive electrodes. So here's a standard clinical array, and this is an array developed by John Viventi when he was in the lab. He's now coming up for tenure at Duke, where in the same area as one of these centimeter scale electrodes, we have 400 electrodes with power multiplexed on this array. We built them with John Rogers from Northwestern out of natural silk and other materials that meld into the brain and have a similar impedance mechanically. And when we recorded seizures in this, here's a standard seizure recorded with a single EEG electrode. And I'm just going to show you what it looks like on the cortical surface. Depolarization is in red, hyperpolarization is in blue. And it turns out these seizures look like spiral waves on the cortical surface, similar to cardiac arrhythmias. This may not be completely accurate because some of this may be a function of the particular model that we used with bicuculline and picrotoxin on the brain, but we're now investigating the spatial resolution of these seizures and trying to understand the relationship of what's on the surface versus what's in the cortical depth. We've made transparent electrode arrays. This is out of graphene. Duigu Kazum is now on the faculty at UCSD. And Flavia Vitali, who's with us, is making them out of Maxine. This is a transparent electrode on a hippocampal slice with calcium imaging of the individual neurons. Look at the filtered version in B. These are the calcium images. This is the electrophysiology recorded by this transparent electrode. You can see the seizure-like bursts here where the cells light up. Here's a spike. This is EKG, and then here's another epileptic burst. So we're trying to understand at cellular resolution what's building seizure precursors and these high-frequency oscillations. We built electrode arrays with John Rogers' group out of dissolving materials so that we can implant these electrodes in brain and not have to remove them, but they can dissolve on their own. We may eventually, because of temporal sampling, send patients home with these intracranial electrode arrays. Flavia has been making arrays that are out of very small fibers, similar to what Nick Balash is doing at Stanford, down to like 10 microns, and building them out of microfluidic control so that they can be moved in brain and record. And some of her materials, like Maxine's, and Flavia runs this area of the lab, have impedance characteristics much better than gold and platinum. They're extremely inexpensive and may replace these noble metals in intracranial electrodes, we hope, in the future. They're also quite biocompatible. So, material science, electrode scale, very important of building the next generation of neuro devices. Understanding the anatomy, working with neuroscientists like Diego Contreras, we've done experiments where we put high resolution 1 millimeter spaced electrodes on the cortex with depth probes through these holes between them to try to figure out where to stimulate in brain, and noticing that seizures begin in these green areas in the depth of the cortex, and there are areas in purple that are trying to inhibit them to stop the seizures from spreading. So good strategies for stimulation may be to strengthen the inhibition of these purple areas and making sure the stimulation reaches the depth of the cortex down here at the bottom, a plot of depth cortex down in the depth layers 3, 5 versus the cortical surface. All right. So materials, algorithms, and now the issue is, how do you actually collect enough data to understand the breadth of human disease? And so this is a group this is what I looked like, 20 years ago with Klaus Lennertz in Bonn. This is in front of a house where Beethoven played very often. We put together a group to share EEG and electrophysiologic and imaging data for seizure detection and prediction. We built a platform called IEEG.org, funded by the NIH. It was supposed to service 100 labs at the end of 4 years. It's still going now, 7 years later, and now there are over 5,000 people that are using it and sharing data, and this is a map of where they are around the world. We built a commercial version of this platform. Joost Wagenaar, who I mentioned was at Pitt and Carnegie Mellon, called Blackfin. He's now coming back and making the platform open source at Penn. It's going to be called Pensive, and it's a place where we can share data. There are APIs to analyze it in MATLAB, in Python, in R. They can display imaging, pathology, time series. It'll be open source, inexpensive to use, nonprofit, and I hope that people will be able to avail themselves of it to accelerate data sharing. We worked, this group chaired a panel for the NIH and DARPA and multiple agencies, NSF, about building an open data ecosystem for the neurosciences, and we published this paper about it. And one of the things that we've done is made an open source area to publish data of all kinds. It's on the cloud, it's on Amazon, it's free right now. We're going to be transitioning this to Penn as well. The idea is you publish a paper and you publish your data, you upload it to, right now it's called Blackfin Discover. It'll be Pensive Discover or Penn Discover soon, starting in April. You can get the data set. This one's 42 gigabytes. There are descriptions of the files, what's in it, who built it, and then it gets a DOI so that the data set can actually be referenced like a publication, like a paper. And what we're trying to do is to change incentives for data sharing. So right now, if you develop data and collect it and spend your money, time, and effort, you keep it to yourself and you compete with me to publish papers and to get grants. But just like the H index for publication is used to judge people for tenure, we're suggesting, and I presented this to the National Academy of Medicine, an S index or a sharing index, where you get credit for how many people use your data and reference it, and the quality of the publications it's referenced in. And if institutions promote people partially on their S index, as well as grant agencies take that into account, we think that it will dramatically accelerate science because you'll want people to share and use and quote your data. We've also been using the cloud for devices. Remember, I mentioned that computational power is a huge problem with the cloud. So we've been experimenting with ways to use complicated seizure prediction and other algorithms for titrating stimulation and control by having devices send snippets of data to a phone or a personal digital assistant, having that send the data up to the cloud, the algorithms get retrained and put back into the device. Again, the device is isolated from the cloud. It only communicates, with a dedicated PDA or with your phone. So we published several papers on this, and we think that it has legs. and a way that devices will leverage the cloud. Again, they'll have to have default or safe modes to operate in for those periods where they can't talk to the cloud. But right now, we're getting quite a bit of traction out of this, and we think it has a bright future. So finally, epileptic networks. So remember at the beginning, I talked to you about that patient and trying to find her network. So we've been working with Danny Bassett, and Ankit Kambadi was one of our postdocs who's at UCSF now, developing these models for trying to understand and which nodes and which electrodes that are placed are driving synchronization of the network to cause seizures and which are inhibiting it. We've published some papers more recently about trying to predict which nodes or areas we should lesion or with a laser or remove or modulate with a device to inhibit that synchronization in the network without having to remove the whole network, because it's just not possible. So we've developed pipelines to figure out exactly what's been removed or ablated by the surgeon in an automated fashion, and then found that in networks that are amenable to brain stimulation or laser ablation, these areas that are responsible for synchronization have a drop in synchronization where the seizure starts, that's in blue, as opposed to the areas in red, which indicate not a response to affecting seizures if they're ablated. And this broadband ROC curve in red is an idea in these 28 patients about how well it predicted response to surgery. We've also found that if we map these areas in the brain, desynchronizing the red, that's fighting against seizures, versus the blue, which is encouraging seizures, when we remove this gray part, this abnormality in this patient that was in the blue synchronizing area, that patient's seizures stopped. In this patient, where the red desynchronizing regions were removed and the synchronizing ones were left alone, the seizures did not stop and the patient did poorly. So we're building these models, and they show, data and inform the physicians in a way that the reading manually of the EEG does not. In this case, the clinician may have been inclined to remove this area initially because it looks like the seizure starts here, but the algorithm indicated it started here, and this made the patient seizure free. Similarly, the other way, the seizure looks like it propagates here early, but that wasn't where the seizures started. We're finding that these synchronization models can show, in this case, there's a clear lesion that shows this polarity with, blue on one side, red on the other. In this case, we saw the same pattern. There was no lesion on MRI, but at pathology, there was one. So it used to be that the way clinicians judged where they found where the seizures looked like they were starting, and they removed a large area of brain. But it turns out that it probably makes more sense to remove the areas that are synchronizing, in this case blue, discreetly, but not removing the areas that are resisting seizures. And that's a big change in clinical practice. So what about impact? So I've showed you basically a problem that I thought it was important, that I know what I'm good at. I think I'm good at getting people to work together in teams to focus on important problems. And I've tried to use every tool that I have to bring to bear, getting material scientists to work on new electrodes, getting imagers to work on new techniques for imaging, getting computational scientists to work on network models, all focused on the application, the thing that I'm passionate about, which is developing devices, surgical techniques, new implants, methods of putting data together and stopping epilepsy. The question is, what do you need to know? And this is a paper I'll refer you to that I wrote a few years ago about technologies and knowledge that we think the next generation of brain scientists like you, neuroengineers, need to know. And I'll just summarize a few. You need to know how to acquire data really in a practical sense, meaningful data, and how to wrangle it and get the formats and all of that working together to put it into a way that you can draw meaning from it. You need to know signal processing and programming, at least the basics of it, regardless of what you do. in neuroscience or neuroengineering. You need to have an understanding of materials and biocompatibility, basic neuroanatomy and physiology with a specialized knowledge of what you need to know for what you're doing. You need to understand hardware. There are complicated systems, but it's not good enough to just be an educated operator to know which button to push, but you need to know how it works, what the flaws are, its weaknesses, its strengths, and understand the limitations of the hardware. Statistics is huge. Machine learning, data science, really important, but boy, you need to understand the statistics and what meaning is. Multiplicity is still a huge mistake that we see. P-hacking, a huge mistake. Learning to use the cloud. There are going to be very few applications, particularly as data increases, data rates, sensors, computation becomes cheaper. The cloud is key. And you need to have a vision of the big picture. Know the meaning of what you're working on, know why it's important, and be able to convey it to somebody in 3 minutes, your elevator pitch. So go back to the pearls. I figured out what's important to me, but you need to do that yourself. I think I know my strengths and my weaknesses. I had a graduate student come and rotate with me once who wanted me to explain some very complex machine learning. I'm an MD. I collaborate with people who are experts in computer science. When I couldn't explain this to him, he looked at me and he said, you're a poser. That's kind of a rough thing to say to somebody, but I said, not at all. I don't claim to know this stuff, but I do work with some of the leaders in the field. Why don't you go talk to this person? So know your strengths. There's no need for you to claim knowledge that you don't have. Find somebody who does and collaborate with them. I had some great mentors, clinically, scientifically. I still rely on mentors to help guide me because even though I'm 60, there are people that have more experience than me in areas that I just haven't dwelled in before, and I rely on them. I've taken some chances. I was relating, when I said I wanted to go into bioengineering half-time and share my appointment, my chairman of neurology tried to fire me because he thought that I was seceding from my department, as opposed to seeing the brilliance of spanning different departments and infrastructure. I've taken some chances and I'm really glad for them. In some sense, I wish I would have taken more, but my career's far from over and I'm doing new things every day. Seize the opportunity, pick a thing, be creative, pace yourself. I think happiness is important for productivity. Roz, let me ask one thing. How much time do I have? Am I about near done or do I have a couple more minutes?
If you want a couple of minutes, you have them.
I just want to show you guys something really fun because it's a pitch that I made and I'm just going to show you it in 2 minutes that I made to the NIH. So I got this thing called a Pioneer Award recently. It's a big deal for me. It's a big grant, but it's high risk, high reward. And so the idea is that you give a grant application and it's 5 pages. And I started this grant with a man walks into a bar because I always wanted to start a grant with a man walks into a bar. And the idea was that he has a beer and he has a device in his head because he's a veteran and had a war injury. And he has seizures, but nobody in the bar knows that he has this device in his head. He drinks a beer and he gets a message on his cell phone. And it's his device. And it's saying, what did you do? Your chance of a seizure just went up by 60%. And he voice texts the device and says, 20-ounce beer. And the device says, I'll remember that. I'll stimulate for now. I'll warn you if you need to take a medicine or you need to sit down, but I wouldn't have another one. And so the idea is that this high risk, high reward grant was to build devices that talk to their hosts and communicate. And I'm just going to show you what the outline of the device is. And I'm not going to go through all of these slides, because I've talked to you about them a little bit, and it would be fun to go through and tell you. But so here's the device. And the idea is that the device is what I've told you. It has sensors in the brain. It may have other sensors, and it computes with the cloud seizure risk, and that it conveys the risk to the patient. But the thing that affects the patient's health the most is actually his behavior. Did he miss a medicine? Does he feel like he's going to have a seizure? How secure does he feel? And so right now we have devices that are just threshold devices. They detect something and then they stimulate to try to turn the seizure off. But they really should communicate to you. If you have a defibrillator and you're throwing big runs of VTAC, it won't tell you to stop running. It won't tell you to take a nitroglycerin. You'll find out when you go to your doctor a month later. So the idea is using different kinds of technology like reinforcement learning to have the device teach the patient and the patient to teach the device. Why did I show that to you? The reason I showed it to you is because that's a risky proposal. That's like the hardware doesn't exist. The software doesn't exist, but the building blocks are there. It's possible, but it's a chance to dream. And so I'm showing that you don't have to stop dreaming when you hit 60 years old. You don't have to stop being creative. And you can think of wild and crazy things. And maybe once in your lifetime, somebody will give you $5 million, unrestricted, no budget, for 5 years to kind of explore your dream. So anyhow, these are the agencies and the grants that have funded my work. This is Michel Morawski and his wife. Michel Morawski was a Holocaust survivor who was a cardiologist, trained in France, ended up in the United States and got an idea for a device to stimulate the heart to stop arrhythmias, which were killing people after heart attacks. He went to the heads of cardiology at Johns Hopkins, and he said, I want to build this device to shock the heart. It'll detect when there's atrial, when there's ventricular tachycardia or asystole or fibrillation, and it'll stimulate. And they laughed at it. He went into the basement of a small community hospital in Baltimore, Sinai Hospital of Baltimore, and he built the device with an engineer from the Hopkins Applied Physics Lab. They tested it on dogs and it worked. They went to Hopkins and they said, we've built this device. We want to test it on humans. The only person who would do it and implant it in a human who was likely to die from an arrhythmia was Levi Watkins, the first African-American cardiothoracic surgeon in the United States. That device is called the Automated Implantable Cardiac Defibrillator. In a span of a year, it replaced a $2 billion market for antiarrhythmic drugs because it was so much more effective than the medications. There's a guy who knew what he was good at. He had a dream. He made it important. And he was a major contributor to the world. And actually, his foundation is one of the groups that supported us. So thanks so much for your attention. Happy to take questions. Sorry I talked so long.
Thank you very, very much for that excellent presentation. I'd like to open up the floor for questions. If anybody in the audience wants to ask a question, please through the Q&A or raise your hand.
Don't be shy.
Here's question number one. Thank you for the great talk. Do you think it is generally wise to wait to take a high risk, high reward project until you're well established in your career?
Well, so there are a number of faculty here who could answer that question. Here's what I'd say, that if you're working and you start your retirement fund with your first job, do you put all of it in bonds or do you have a diversified portfolio? And so what I'd say to you is that it's the same with research. You absolutely should use bread and butter, conservative, go for the singles, go for the doubles, get your preliminary data, file your first grants, but it's okay to have in your portfolio that one thing that's a moonshot. Now, I wouldn't put all of your research time and effort on like 5 black on the roulette wheel, but I think it's fine to have a portfolio where you have the majority of your research in blue chip investments and have just a little bit invested in that high risk, high reward stuff. But what do you think, Ross?
I think I am going to echo what you said. My situation or my approach was quite similar. Started out with what I knew, what I was good at, got my grant that way. And then while that was going on, towards the end of that grant, I started doing more risky things. And once I got tenured, I did even more risky things. That's how I approached it.
I will tell you one thing. So that Pioneer grant isn't the only grant that I wrote, right? It's also not the only Pioneer Award that I wrote. I've been turned down 3 other times for a Pioneer Award. So, but it was 5 pages. Like now, it's the longest I've spent writing 5 pages, and it took longer than the 20-page R01, 12 pages for the R01. But it was worth it to do that on the side. Was I counting on that to support my lab? No, the chances of getting one of those are like getting struck by lightning, but it was like a huge thing. And when it finally came through, it was great. And I'm glad I was like still young enough to actually do something.
Here's another question. Tracy Sweet says, amazing talk. I see you have over 1,000 unread emails in your email inbox. How do you manage that?
Oh, man. Most of them are spam. I have administrative assistants who help me with that stuff. Some of that is email that I ported over, but some of it is stuff from Raj that I should have answered last week.
All right. Very good, Tracy. Another question from Carla Gonzalez. Is there any indication of why Medtronic decided to keep their Activa RC for research purposes only? Thanks for a stimulating talk.
You know something, I wish I knew. Like that device is like a godsend for us. And the NIH has a bunch of grants that are relying on it right now. I don't have insight into what goes into these corporate decisions. Some of you may have noticed that I showed you all of those companies that I'm involved in, but I've told you that despite that, I haven't made a dime off of them. Some consulting, yes, but not off of equity in any of them. So that's evidence that I am not a good businessman. So you could not really rely on my decisions. I don't know why, but I assume that that the applications of it or the support of it may have been more involved than what they wanted to do. But that's a question that I've tried to ask Tim Dennison, who is in charge of the program, several times, and he has not given me a straight answer. I do know that he left the company to go into academia, but that may be completely unrelated. So you'll have to ask them, but if you can encourage them to support it, it would be wonderful. It's a great device.
Here's another interesting question, a good one, I think. First of all, thank you for a great talk. Is there any certain stimulation patterns for the electrodes to stop the epileptic seizures from happening?
So the answer is absolutely not. I mean, we don't know why. And sometimes you'll see that the stimulation will stop the seizure cold. And more often than not, though, you see what I showed you, which was those 5 stims that doesn't work. I think anybody who can figure that out would be a huge help to patients. It's not straightforward. And one of the frustrating things for me is you would think if you were in charge of that company, you would have a set way of titrating the stimulation for every patient, and you would do some kind of gradient descent method to search the parameter space. They don't do that because each patient is so different. The docs like titrate 50 different parameters, and there is no clear recognized way to stop these seizures. So great project. Somebody figure that out, please.
Excellent. Any more questions?
I have a question I'd love if one of the students could answer it. Like, are any of you thinking of going into neuroengineering? And what are you thinking? I mean, how do you guys feel about your prospects in this industry for jobs? Does anybody want to comment?
Yeah, please raise your hand. I will enable your audio.
Everyone's feeling shy.
I will tell you that there are huge opportunities in this field. Those companies, that slide that I put up, 4 catalyzer companies, Siemens, Medtronic, Boston Scientific, Hyperfine, Tesseract, Liminal, all those, they're all looking for people. They're recruiting like crazy. And I would absolutely, it's an area that there's a lot of opportunity, but they do want people with specific skills in a lot of the areas that I mentioned. So I would absolutely look at this field as one that has tremendous possibilities in academia, because neurological disease and neuro disorders are growing dramatically as the population ages, but tremendous opportunity for devices, therapeutics, all sorts of things.
Do you think that the level of qualifications these companies look for are at the PhD level, master's level, bachelor's level, all of the above? What's your take on that?
So I think it's all the above. In the end, I think it's what you can do that separates people. I know that they're looking for signal processing people. They're looking for people with regulatory experience, with electrode experience, people with magnets, MRI, imaging experience, clinical experience. So I would say the most important thing, get training in the classroom, but internships, research experience, do stuff. It's what and I'm not sure what your diploma says is as important as what you can actually do. Would you agree?
Oh, yeah, I absolutely agree. In fact, we're starting a professional master's in neural engineering aimed to produce people with these types of qualifications in different concentrations within neural engineering. That's precisely the idea. And so I couldn't agree more.
My course gives people very practical experience at building algorithms for devices. And I give them nasty, gnarly, real life data with all the noise and artifacts and all that in it, because I think it's really important to try to solve real world problems and to struggle.
Yeah, I know we're approaching on the 5:15 mark, but I still have a couple of more questions. Would you be willing to field them? Thank you.
Yeah, sure.
Again, thank you for the great talk. Do you think that the algorithm and devices for seizures would also work with people who have multiple sclerosis?
So multiple sclerosis is a different kind of thing, right? So that's an interruption of connectivity or conduction between the brain and the central nervous system and the peripheral nerves. So there, what you're doing is losing signal fidelity. You have a message that's originating in the cortex that you're trying to get out to move your arm, but the signal isn't getting through because it's dispersed and the connections are disrupted. Whereas in epilepsy, you're actually trying to disrupt the connections. So I think, multiple sclerosis is a different problem. It's picking up the neural code and then bridging it across damaged neurons. Needs a different kind of solution.
Excellent. Okay, next question. On behalf of people who are still figuring out what they are passionate about and their abilities to contribute to it, was there any specific point or period that you realized that you wanted to help people to cope with seizures? And would you say there are any specific things you explored that somehow led to that realization?
So that's a key question. And you know what? It reminds me that I left something out, because I mentioned mentors as people who can guide you. But I think what got me involved in the fields I'm in are not just the content, but meeting dynamic people who inspired me. So Bob Fisher, who's head of epilepsy at Stanford, was a guy I ran into when I was, a medical student, and I just thought the guy was the most brilliant, funny, interesting person on the planet, and he made his field come alive. When I was an undergraduate, I worked at the Hopkins Applied Physics Lab with a great computer scientist. And when also in college, I got a job doing systems programming I had a skill. I could do assembly language programming, and they needed to program their isolated heart experiments. And I worked for a guy named Bill Hunter and another one named Kichi Sagawa. And I just thought the work was incredible, but also the people were incredible. So I think the more experience you can get, the more exposure to things and people, the better. And it's going to change. I really was inspired by the Hopkins Physics Lab stuff. But then I met Fisher and I was like, whoa, not only can I do the science, but I can find a biological application, which is great. And I made mistakes, right? Like I entered an internal medicine residency and applied and matched in it. But after that, I did a rotation in neurology where I met Fisher, and I was like, oh my God, I like this so much better than what I'm doing. And I continued with him. And then I ended up going to the chair of internal medicine and asking him if I could leave the residency because I picked the wrong one. Although I told him I was willing to stay because I committed to him. So that's the integrity part, right? And he looked at me and he said, no, you don't need to stay. We want to get you to where you want to go. So take chances, make mistakes, and don't be afraid to change tack, but do it with integrity.
That's wonderful advice. Absolutely. Thank you, Dr. Litt, for a wonderful session. And thank you for fielding these questions. I'm sure these students really enjoyed it.
Thank you so much for inviting me. And, you guys can find me. I'm litb@upenn.edu if you want to follow up with a question or a hello or whatever.
Wonderful.
Thanks.
Thank you.
Take care.